What happens when the inside of your knee or when you walk hurts and people point just to the inside or outside of the knee? And it's really one location that's really bothering you. Then I think you could be a potential candidate for a partial knee replacement. And a partial knee replacement is where we only replace the portion of the knee that is damaged or bone on bone. And so the reason I like to do this is because the outcomes are better, the knee range of motion and flexion is better, it's a faster recovery, less infection risk, and overall the patients are much more satisfied than a full knee replacement. Not all patients are candidate, but you should ask if you are and get a second opinion if you're not getting a good explanation why you aren't. The reason why partials, I think, do better is that you keep your ACL ligament and your PCL. In a total knee replacement, these are completely taken out by most surgeons. And so patients feel potentially unstable. They don't know where their knee's at in space. When I do a partial knee replacement, I don't have to do any type of more exposure than a mini approach to the knee, shift it out of the way, and all I really see and work on is one part. I don't have to dislocate or sublux the knee, so the swelling's less, and I'm able to put parts in that when you do a partial knee replacement, you're only removing about 4 millimeters of bone around the femur and then gluing this on to restore the anatomy, and then replacing the damaged part with a piece of plastic you're gluing in, and you keep the rest of your knee. So you keep your ACL, your PCL, the outside, the kneecap, and because of that, people feel like you solved the problem without redoing my whole knee. So I recover faster, it still feels like my knee, I'm able to be more athletically performance oriented. This is what I would want if I'm a candidate 100 times over. Now, there are risks to this, and that partial knee replacements can fail. And if you follow the fixed bearing data, it's around 4% at 2 years. However, once you hit that mark, it wears the exact same with the exact same failure rate as a total knee. So really the risk is in the first 2 years, and that's either for fracture, for loosening, or continued pain. And so the bailout option is always a total knee. And so that's the way I like to think as a total joint surgeon is, can we do less and get a better outcome? And the answer is yes. But what happens if things go wrong or the patient's still hurting? You can still do a knee replacement, and the outcomes show that it's equal to that of having the knee replacement the first time. So it depends on your risk-benefit analysis, your personal risk-reward for yourself. Everybody's different. How I would want this handled if I had isolated arthritis is a partial 100 times over.